And a happy new year to you all, and I hope everybody is ready for a busy year, because it's going to be one. Today we're going to talk about codeine. We're going to talk about give you an update on the changes to access to codeine, and then what this means for pain management. There's me, Jo Root, the policy manager for CHF here, and I'm joined by Carol Bennett, known to many of you, I'm sure, on the line. Carol is the CEO of PainAustralia, and together we're going to take you through.
Thanks.
So this is what we're going to talk about. We're going to talk about what's happening in codeine very briefly. I'm sure most people do know this, but we just want to check we're all on the same page. Why we're having the change, why we're upscheduling codeine, the Real Relief campaign, which Carol will talk about in more detail, and the National Action Plan for Pain. And then I'll finish up with the Consumer Resource Kit. We have some spaces for questions, and as many of you know, you can go into the chat room and have your chat. You can put your questions in there. We will collect all the questions and answer as many as we can in the spots that we've made available. We're not really going to stop in the middle of the presentation. It becomes too difficult with people, so you might have to wait for your question to be answered. So I'll just ask you to be patient. So what's going on? Well, the reason we're here is that from the 1st of February, medicines containing codeine will no longer be available without a prescription. And that includes medicines for pain, analgesics combined with paracetamol or ibuprofen, and cough and cold preparations. It's worth remembering that you will still be able to get codeine products on prescription. So the government hasn't decided to not have any codeine at all. The decision was made by the scheduling delegate of the Secretary of Health on the 25th of December 2016. So that's sits within the Therapeutic Goods Administration. This was after extensive public consultation. There were 2 rounds of submissions. It took a long time. There was lots of toing and froing on what should or shouldn't happen. And it was discussed at 2 of the meetings of the Advisory Committee on Medicine Scheduling, once in August 2015 and March 2016. So we've had the decision for over 12 months, and the change is just about to come into effect. There's been a large range of activities to prepare for the change because we have had a long period of time. If you think it isn't very long, you need to look at what happened in France, where they made the decision one day to reschedule it effectively at midnight that day. So that was a bit different to giving people 14 months notice. We've been doing a number of things have been happening. There's been training for pharmacists and pharmacy assistants run by the Guild and the Pharmaceutical Society of Australia, and that's helping pharmacists with how they deal with people who want codeine, what are the alternatives, how they can give some advice on pain management that doesn't involve an over-the-counter codeine. There's been discussions with doctors and other health professionals, particularly dentists, around when to prescribe, what are the alternatives to prescribe, and to have a look at broader pain management issues with people who present for codeine. I think it's worth mentioning here that we know that it's not only a problem with over-the-counter codeine, it's actually a problem with prescription codeine as well, and that needs to be addressed. And more recently, we've had consumer messages through PainAustralia, through CHF, MPS Medicine-wise and Script-wise. So there's a lot of activity been going on behind the scenes. There's been a lot of toing and froing. There's been quite a lot of media on this, so I think most people are probably have some knowledge of the change, maybe don't understand it completely, but hopefully we can all work together to help people understand the change and make it work in their interests rather than being a negative. When the 2 issues that came up to the reasons for changing access, the main issue was safety, and then there was also efficacy. And when the delegate is looking at a scheduling decision, they have to take, the TGA has to consider a number of issues. They have to look at the safety of the medicine, the seriousness of the condition for which it's being offered, effects when it's used correctly, how does it, is it good when it works correct, when it's used correctly. Side effects are important. And here's where in codeine it becomes an issue. Likelihood of accidental or deliberate misuse, effects on children, effects of an overdose, potential for people to become dependent, and benefits. So basically, when looking at the scheduling, the TGA has to look at all those issues and decide, is it going to be a medicine that is a general medicine that is available in a supermarket, available anywhere? Is it going to be an S2 or a medicine that's only in a pharmacy? Is it going to be an S3, which is behind the counter and only available after consultation with a pharmacist, which is what most painkillers, analgesic codeine was used for, was scheduled? And then is it prescription only? And I guess the decision that was made by the TGA, by the scheduling delegate, and by the advisory committee, that on the balancing up the benefits of using this medicine against the potential harm, it was felt that being an S2 or an S3 was too low a classification, that actually the potential for dependency, potential for harm was higher and outweighed the benefits. I think in coming to this conclusion, and the why this debate started, is that it was just seen that too many people were dying from codeine. Codeine-related deaths have doubled between 2000 and 2009, and although 2009 is now becoming out of date data, we have no reason to think that anything has really changed in that period. If anything, the problems got worse. We look at 100 deaths directly related to codeine a year, so that's 2 a week. So this is not an insignificant problem of serious harm from using codeine. And they also look to what's been happening around the world. You know, what are other countries doing about codeine? And by moving from over-the-counter to prescription only, we're lining up with the majority of other similar countries to ourselves that have concerns about safety, and they want to so we're lining up. So we're not doing something that other countries haven't done. It's pretty straightforward, really. If we look at safety, there's a number of elements going through that list that the TGA has to consider. And concerns were raised about the fact that codeine is an opioid, and it is quite easy to become addicted to codeine. Many people are not aware that they're addicted. They just start to use more and more. They don't see it as an addiction. They probably wouldn't identify it as an addiction. And probably when we think of people who are addicted to drugs, we probably wouldn't think of people who use over-the-counter codeines. But it's quite clear that it is very addictive. It's easy to become hooked, and it's not easy to get off. So there was a problem of addiction. There's a problem of the quantities that people were using, and particularly as often as an analgesic, it's combined with paracetamol and ibuprofen, because they themselves can cause harm if used in excess. So as well as having the harm of the codeine, you are having the harm of using increasing amounts of paracetamol and increasing amounts of ibuprofen, and with liver problems and stomach problems and a whole range of problems that go with using those medications in excess. There was a high potential for misuse, intentional self-harm. It's been seen that you know, people use these codeine containing preparations to deliberately hurt themselves, attempted suicides, a range of other intentional self-harm. And then the accidental overuse and misuse was a problem. People don't use them properly. They don't understand the risks. and just continue to misuse them. And we know that they're not used according to the directions in many cases. So there were all the safety issues. And around 40% of codeine-related deaths were involving over-the-counter products. So of the 100, we could say maybe 40. So we need to, we thought, even one is too many if we can avoid it. And so that was some of the thinking that went into that. The other side of the equation is the benefits to people. What do you gain from using this medicine? Does it work? And the research is now consistently showing that because of the very low doses of codeine in over-the-counter preparations, they really are little, if any, a benefit when compared to similar medicines without codeine. That they're not effective for long-term or chronic pain, and really codeine doesn't work for pain beyond 3 days. So for anybody who's got, we all think of chronic pain as going on for months. Well, 3 days is not very long. So if it's not working, if it's not going to work over 3 days, then you need to have a plan B. You need to have a different pain management approach for something that's going to last longer than 3 days. So it's not effective. The evidence shows that other combinations of medicines will be just as effective, and one of the most common talked about is combining paracetamol and ibuprofen. Does provide as much pain relief as a medication with codeine. And then there are other non-medicinal approaches to chronic pain which can be as effective, and perhaps people are missing out on those because they are using codeine, and I think that's one of the problems. The other is that there are safer alternatives for acute pain. For short-term, for sudden onset pain, often people talk about toothache. There are alternatives. Codeine is no more effective than the alternatives for that acute pain. So I think those limitations on efficacy and the safety concerns combined can show, if you think about it, that the balance is not right for consumers, that the risks are too high and what they're gaining from it, and any sort of any benefit analysis would tell you that that's not a good place to be. You want to raise it that the benefits have to significantly outweigh the safety concerns. And we also need people to be aware of the safety concerns. Since the announcement of the scheduling, people have raised a number of concerns, and we continually hear these. CHF itself, in initial responses to the discussion about upscheduling, raised some of these and said, we have these issues. What are we going to do about them? And I think some of them are still genuine concerns, and we need to try to address them. This is why CHF and PainAustralia have been asked to do some more consumer awareness raising and messaging so that people see that they're not sort of just being abandoned, and that there are good reasons for the decision and that there are alternatives. People come to us, and I'm sure they've come to PainAustralia in response to, and you've seen it on Twitter and you've seen it in social media generally and in articles in the press. There's nothing to manage pain. If I can't have codeine, well, how am I going to manage my pain? People can't see beyond codeine. There are a range of alternatives. And I think where people go for these alternatives is important. We would say, you should be talking to your health professional. You can talk to a pharmacist initially. Pharmacists will give you alternatives to using codeine. And we want people to talk, if they've got chronic pain, we want them to be talking with their GP or with their specialist about how they can manage their pain. What are the alternatives? Where are they available? And as I said at the beginning, there still will be some codeine for some people who have a need for it and where it is seen to be beneficial. So it's not out of the equation completely. people have said, why are you penalising those who use it responsibly? There's a view that most people are using codeine responsibly, and consumers have the right to use it if they're using it responsibly, and that they're somehow being treated badly by not having access. I think the issue goes back to the efficacy and safety argument there. People often don't have an understanding that it is quite addictive, and it's easy to become addictive or dependent. The other thing about opioids is that people's bodies react to them differently. So what might be safe for me may not be safe for Carol, because we metabolize it in a different way. And so there's no firm thing that it's safe for you or not safe for you. So I think there's a lack of understanding about how what are the potential harms from codeine, and the risk of unintentional overuse is high because of that. So we want people to see this, I think, as an opportunity to have a look at alternatives that will be safer for you to use, will be safer for consumers to use, and will give you, in many cases, better pain relief, I think it's fair to say. So we would argue that point, and that's address that concern. Cost has been raised by a lot of people. We've had a lot of people say, well, now I've got to pay to go and see the GP to get my script before I can get codeine. And I guess we would say, well, yes, if you want to have codeine, you are going to have to go and talk to a doctor about it. But that's an opportunity to talk to the doctor about how to manage your pain. What is your pain? What have you been trying? What is the cause of your pain? So to have a thorough discussion and assessment from your doctor about the cause of your pain, and to look at alternatives. So it wouldn't necessarily be an additional doctor visit. If you're already seeing a doctor for pain, then you're going to just talk to them about the pain. And if you might not need codeine, so you don't need to go and get a prescription, and you can try some of the other things that your pharmacist might suggest to you, or alternatives that another health professional, such as a physiotherapist or a dentist or whoever it is that's working with you with your pain, might be able to suggest other things, so you don't ever need to incur the cost of going to the doctor. And we at CHF would argue, and I'm sure PainAustralia would argue as well, new causes of pain should be investigated. You should find out why you're getting the pain, what is causing the pain, and then have a discussion about what is the best way to manage that pain. And I think this is, again, an option to try to get your pain, a good pain management plan in place. People have said there's limited access to alternatives. Yes, physiotherapy is expensive. Yes, I don't have access to that. I live in a rural and remote area, and I don't have access. I think it's fair to say that most people will still they'll certainly, living in a rural and remote area, probably will see a pharmacist. So there's already an alternative there for you to talk to the pharmacist about what it is. Again, it's how you access your GP or your specialist, and accesses to specialist pain clinics. And Carol's going to talk about the National Action Plan. We all agree that we need more resources for pain. We need more specialist pain clinics. We need more pain support. We need more pain management units in hospitals. We need to have a look at what else it's doing. So this is an opportunity, I suppose, to seize that advocacy. And then, where do I get help if I think I have a problem managing without codeine? And we would say that you need to be talking to your GP, and that's not an easy conversation to have. And GPs need to be talking to you about it as well. We think that actually this is an opportunity to have a look at what we do to help people who have an addiction. And CHF, and I'm sure others, have argued that improvements in access to addiction services needs to be part of what we offer when we move people off codeine. But that that's actually in many ways, the people who cannot manage without codeine are part of the important part of the target group for this measure, that we need to get people off what is a damaging and harmful drug onto something else. And then, what about abuse of prescription codeine? People often say, and seen it on Twitter, and saying, well, it's only over the counter isn't the main problem. People abuse prescription medicines. They go and they doctor shop, and now they'll still be able to doctor shop and still be able to go and get lots of codeine from different places. I think that's certainly an issue. I think the medical profession, I think the College of General Practice, all the pain management doctors, all the specialists, and know that we need to look at our prescribing of codeine and our prescribing of opioids generally. And so it's part of a bigger problem. And I think some, doctors will tell you that they easily took up prescribing opioids without fully understanding the consequences. And now we've got data over a longer period of time. We know it's harmful. We know it's addictive. We've actually got to change prescribing habits, and doctors have to do that as well. So we fix the over-the-counter part. Not very helpful if all that happens is somebody can just get it from their GP. That's actually not solving the problem long term. And another part of that is looking at real-time monitoring of prescription medicines to stop people doctor shopping, so that we can see that somebody, people do doctor shop. Scriptwise is an organisation which looks particularly at misuse of and overuse of prescription medicines, and some of their stories are predominantly about people who are able to get almost unlimited supplies of prescription medicine. So we clearly need to do something about that as well. And that's basically where the people have comments. So I might stop there. I feel like I've been talking forever. And see if there's any questions. And I'm also interested to know, Di Trimble I'm also interested to know what the guidelines for GPs will be for management of people with chronic pain. Do you want to talk to that, Carol?
Well, I think the College of GPs back in October or November of last year actually issued some guidelines on management of chronic pain. And there's certainly quite a bit of education and training underway. I know that the Australian Pain Society have quite a bit of education and training that looks at how to manage people with chronic pain issues. And there's quite a bit of work already being done in that space.
Yeah. So is there any other questions for us, Dean? Okay. So there's no other questions coming through. I think some of the chat is saying, yes, we need more of other things. We need more physiotherapists. We need more multidisciplinary pain management clinics, which I think Carol is going to talk about. And I think this is a good question, I think. Has any consideration been given to the possibility that those who've been using codeine combination medicines start to take more of the paracetamol-only products? And again, it's not difficult to overdose on paracetamol. I think that's a good question. I think that's why we're stressing in all of our messaging that if you have chronic pain that isn't working, you really need to go and get and your pain relief's not working, you really need to go and have a pain management plan. You need to go and get some help. Pain might be individual, but you don't need to manage it on your own. And we would be saying to people, there is help out there, you need to go and get it. But that is a good point. I think we're going to have to keep an eye out for that in terms of presentations of overdosing on paracetamol. That can happen now, of course. People don't need to go to codeine. And that's part of the problem, that people take more and more of these low dose ones, and so actually are overdosing on paracetamol, and doing significant damage to their livers, and ending up in emergency departments and presentations that need dealing with. So that is an issue. I think that's okay. Affordable access to alternative physical treatments versus pharmacological interventions. Yes. I think we would agree with that, and I think this is part of the issue, that allied health tends not to be under Medicare rebate. You might get the 5 MBS items for allied health for physiotherapy as part of a chronic care plan. 5 isn't very many, and they're not necessarily going to be bulk billed. So we think, yes, that is part of the issue, and I think when Carol talks about the National Action Plan, that'll be something that she will cover in the next part of the presentation.
I guess the only other thing to say about that, Jo, is that we do know that alternative treatments, non-drug treatments, can be very effective. In fact, we've seen stats, up to 80% of people can actually get effective pain relief with alternative treatments and therapies that is suited to their condition. So we know it works, and we know what works, but it's about ensuring that people have access to affordable treatments that are effective, and that's a real, I guess it's a challenge for Australia as a country that really hasn't necessarily dealt well with pain management. And what this codeine issue has highlighted is that we don't have a codeine issue, we have a pain issue, and we need to actually manage pain much more effectively and take it very seriously, because for people who experience chronic pain, and we know there are millions of them, it's a very serious issue for them, and it really does impact on all aspects of their life. So we need to make sure that we do much, much better. And, this is an opportunity, this is an issue that highlights how important it is to do that much better.
Okay, I think probably we should move on to the second part of the presentation. We will have another opportunity for questions after Carol's been through hers. So we might.
Okay. So I'm going to talk a little bit about the Real Relief campaign, which is a campaign that PainAustralia has led, but in partnership with input from a range of groups in the health sector to try and provide information to consumers. It's a social media campaign, essentially. It's intended to provide evidence-based information to consumers about codeine, the reasons for the upscheduling decision, and alternative ways that they might be able to manage their pain. It was developed, as I said, in collaboration with 10 other partner organisations and key stakeholders in the health sector. It's based very much on feedback from social research. So we've actually gone out and done some social research that looks at the views of the community and their perception of this change in regulation. And we've based our messaging on the collective views of the partner groups, but also the feedback we've had from that social research. And we've looked at sort of the level of knowledge in the community about codeine, the potential harms, and the alternative forms of relief, and just assessed what people already know and what they probably need to know and how they want to know it. So the majority of the social media has really been intended to drive consumers to the Real Relief website, realrelief.org.au, and there they can learn more about the issue and sign up for more information. We started on the 22nd of December, so we've hit the ground running, and it's been a very short time frame. And the campaign content has been posted daily, both on the Real Relief Facebook page and the PainAustralia Twitter account, using the hashtag Real Relief. Our partner organisations have also been sending out and sharing these messages, and also designing their own messages around the key messages for this campaign. So the content really includes, facts about codeine, references to case studies, information, and other forms of pain relief in particular, and I guess relevant links to articles, fact sheets, and the like. The social media content is being supplemented with some paid digital advertising. So there's, for example, some pop-ups that appear when you're scrolling through the website or the Facebook page, and it's been designed to target people with pain. So we've also, as part of that, created a video for the campaign, and that's been used quite extensively. Video that comes. Yeah. Okay, so the tweets are being retweeted extensively by our campaign partners and others. And they're also, as I said, adding their own messages using that Real Relief hashtag. And the reach of that Facebook page has been upwards of 56,000 people, and posts have generated a really good amount of discussion, and really robust discussion, which is terrific. We've also earned a significant amount of free media, which is sort of separate, somewhat separate to this campaign, but across all of the platforms for mainstream media, TV, radio, and press. And the Codeine story, I think, initially appeared in both Fairfax and News Limited media, and in some of the key newspapers, the Daily Telegraph and Age, and subsequently was syndicated, including across Australia in regional newspapers. So I think the strong level of media interest continues, and certainly, as Joe said, there's been quite a bit of interest and quite a bit of awareness raised as a result of that. And we've also, I guess, as part of this campaign, it's coincided with a change.org petition from a consumer who has experienced years of pain, and we have supported that because the call is really for better access to pain services for all Australians, and particularly in light of codeine upscheduling. It does really raise the issue for people of what the alternatives might be and how they will manage. So it's still continuing to attract new signatories. We've currently got upwards of 2,200 people signed up to that campaign. So it does send a strong message. People want to see some action when it comes to the treatment options available to them for pain relief. But overall, the level of media coverage and the social media reach have indicated that there is the message of codeine rescheduling and why it's necessary is actually reaching consumers, and really that was as we intended it to be. In terms of key messages, the campaign messages and the website were, as I said, developed on the basis of social research, which showed that initially consumers were very unaware of the potential harms of codeine. Many were unsupportive initially of codeine upscheduling, but we could see that when people were given information, they were actually influenced when the harms and the evidence were explained to them. And as a result, we've continued to tamper with our key campaign messages to deliver the sorts of messages that demonstrate that the evidence is in place, demonstrating the need for this change. We've aimed to counter the misconceptions about codeine use, to educate consumers about the warning signs of codeine overdose, and about safer and more effective pain management options. There are also messages informing consumers about the changes to codeine access from the 1st of February and how they can still access codeine should they want to continue using it. We've also used some case studies about consumers who have misused codeine in the past and now found much safer and more effective forms of pain relief. And so we're currently looking at some new content based on the feedback that we've received. And that's how we've really used this campaign to gauge community views and input, and then use that to provide more effective messages back to the community. So Joe's talked about the call for a national action plan. I mean, we clearly have a bit of a national pain epidemic, and I think that's really been underlined by this whole codeine issue, and you know, just the figures that we see in relation to the numbers of people both addicted to or misusing or using codeine on a regular basis. You know, they're quite high, and the harms and the overdoses are quite significant and becoming alarming. So I think the underlying issue here is the issue of pain. It's so far pretty much flown under the radar. We've got 1 in 5 Australians, including children and teenagers, who live with chronic pain. 1 in 3 older Australians live with pain, and aged care residents, up to 80% of those residents live with chronic pain. So the codeine issue has really highlighted the need for adequate access to pain services and better education and awareness about safe and effective pain management strategies. In our pre-budget submission, PainAustralia has called on the federal government, and I know that Consumers Health Forum have supported this call to consider. We've identified 16 key priority projects that will help Australia to better respond effectively to our pain crisis. It includes, you know, updating and refreshing the national pain strategy. There is a national pain strategy, and most states and territories are involved in actively implementing that strategy. But what we need is national consistency and leadership when it comes to ensuring that we have a national approach to this issue. We've talked about a national web-based consumer support network, a national summit to reduce opioid use, a national approach to rehabilitate injured workers. We know that's a huge issue, and compensation and the need to effectively help people back to work is a big issue. A mini pain program for rural and regional areas. We've talked a lot about that in relation to the Codeine campaign. Rural and regional areas are, you know, a particular challenge when it comes to effective pain management. And telehealth, of course, is an important part of that. So we've called for some increased support there. So you can download that submission from the PainAustralia website. But essentially, just to give you a quick overview, there are 7 priority objectives, which I think you've seen. Minimising the pain burden is a national priority. Empowering consumers, preventing chronic pain and opioid misuse, minimising the impact of pain on the workforce, expanding pain treatment and consumer support, including regional services and priority groups, building capacity in health and the aged care sector, and understanding pain and its impact through research. And there are 16 key projects. I won't go through them all here, but you can have a look at them. But essentially, they fall under 7 themes, which are outlined there in the boxes on the left. So we would certainly encourage people to support the call for a national pain strategy, and we see this as being really critical to helping people, not only with codeine and the changes that are about to take effect, but in helping them more generally manage, you know, chronic pain in a way that is affordable, accessible, and effective.
Okay, and I guess now we have a chance, if you have any questions for Carol on the pain action plan or the national the need for it or any components of it, this is your chance to ask them. So I don't know whether we've
inundated.
I think there are some, but we might. I'm getting.
That's a really good question. Should I read out the question
Yeah,
first?
yeah.
So Debbie Rigby, thanks Debbie. She's asked, what is CHF and PainAustralia doing to help consumers understand that opioids are not the best management for chronic persistent pain? To understand the biopsychosocial model of pain management, it can be a challenge for GPs and pharmacists when patients expect or demand a pill for every ill rather than change behaviour and implement self-management with the assistance of a pain management plan. Do you want to start with the CHF response, Jo?
Well, yes. This is going to be a challenge, and I think I alluded to this at the beginning, where we want people to see this as an opportunity to move away from the pill, move away from just taking a tablet with codeine, a medicine with codeine in it, to actually looking at what are the causes of your pain and how you could manage it. It is often or has become a common narrative actually that doctors only give patients things because patients insist on having them. The patient bully, basically, and I think sometimes this gets caught up with consumer-centered care being interpreted as consumers should always have what they want. I think it's about having a conversation, and that's what we would say. It's about the pharmacist or the GP having a conversation with somebody about, well, what is your pain? Why do you think codeine's working for you? Have you tried the other things? What are some of the barriers to you trying other things? And I think somebody alluded earlier in an earlier question to the cost of alternatives. So it is about having conversations. I guess it's about having time for those conversations, I would say, and giving people a step at a time approach about, what can we do? Where do we go next? Maybe, alternative medicines. But it is about having that conversation, and it does require both. So I think CHF, and we see a lot of this messaging, and I think Carol does as well. We see it as important that we have a role to say to people, there are other things available that will actually be better for you. We want to go and talk to somebody about what those are. We are going to keep doing those messages, and I'll mention it later, but CHF is putting together a consumer resource kit, which is to go out to our member organisations and anybody else who's interested, which goes over some of these issues. Again, is designed to be used as an aid to talk to people about what happens next and how to manage pain, where to get help, the fact that you're not alone. So I think those are some of our key issues. And
yeah,
what about you?
I think Debbie's last point that changing behaviour and self-management are much more difficult than popping a pill. And one of the dangerous things I think about codeine is that it has tended to mask underlying pain and conditions. And I think this is an opportunity for us, and we've tried to message as much as we can that there are effective treatments for pain management. We've had a number of consumers who've come out and spoke publicly about how they've managed their pain without codeine and how they've overcome that hurdle of feeling the need to use medication to manage pain, and intend to continue to just try and change the culture of pill popping when it comes to pain management, because often pain is a significant indicator of something much more complex and difficult underlying going on, and we want to encourage people to both seek help but also look at the alternative options. We know that they are effective, but it's about changing that conversation, and I think that has been a really useful and beneficial aspect to this codeine debate, is that it's actually made people think, and we've had many consumers say to us, They'd never thought about this before this codeine issue arose, that, you know, why they were taking the codeine, you know, what was actually going on, and, you know, what works for pain, and what are the alternatives that they would then need to go and look into. So it certainly prompted people to both have the conversations, but start to challenge some of the myths and start to look at what is effective pain management and how they can go about achieving that.
Yeah. Is there okay. Wow.
Yeah,
good question. That one?
Good question. Lorraine Bola, to what extent have state and territory governments committed funds to the pain management strategy? It's very variable, and we know that New South Wales has a particularly good pain plan, and other governments, Tasmania, South Australia, Queensland to some extent, WA, they've all committed to implementation or aspects of implementation of the national pain strategy, but funding has been variable. But New South Wales has certainly made the biggest commitment in that regard. And I guess, you know, what we'd like to see is the federal government, in collaboration with the states and territories, you know, coming to the party to commit to a national pain strategy that is, you know, appropriately funded, that actually sets out what governments are doing to manage pain, and is actually funded. I mean, that would be the ideal, but at the moment it's a bit of a mishmash. It's not well coordinated across the country, and, you know, you could argue that it has led us to the situation that we're in, where people are using ineffective options that are easy to access because we haven't got a national response to pain that enables people to manage what is a very complex, you know, and debilitating condition effectively.
Is there any other questions? So this is from Dave, who asked the question about the costs. And I guess this is about, it's a comment really about knowing what needs to be done and needing a whole lot of interventions and how you get those interventions. And I think it raises the question about what's provided in the public system and what's provided in the private system. And I don't know whether you want to talk about that, Carol.
Well, I guess, I mean, even where we have a very good public system, we still have limited options when it comes to access, for instance, to pain clinics. We've got 200 pain specialists around the country. We have some very good public pain clinics and some very good private ones. But obviously, waiting times, particularly in rural and remote areas where it's very difficult to get access to pain services, but also cost is a big barrier for many people, particularly in the private sector, and particularly for you know, allied health services, which are very useful as a component in effective management of pain. So, you know, these are all the things, Dave, that we really do appreciate are very challenging for consumers who are dealing with this issue, and it is something that we want to see addressed as a national health priority, because it is absolutely that issue when you consider that 20% of GP visits involve pain, and that quite clearly, you know, many people are using codeine and other alternatives rather than these more effective treatments that are more difficult to access.
Yeah, and I think, you know, the move of the federal government to go to healthcare homes and to have coordinated care. Within that, one of the disappointments for CHF, which we've been quite public about, and I know others have, is that didn't include more resources for allied health, and that was still kept at just the 5 MBS eligible items. And, you know, even if you can get a physio who only charges the MBS, you'd only get 5. So I think it is. I think that is actually an issue. That is part of the broader issue of how we get people the suite of services that actually are going to work for them, and how we can be more flexible about how we fund those. I think is one of the issues that we need to have a closer look at. I'm not sure.
Mm.
Well, yes, there are S4 codeine products available. You just don't need to go and get a script.
Mm.
You've always been able to. Yes, you
Mm.
can get one. Some of the manufacturers of the low dose codeine that is currently S3 have indicated that they're not going to keep those products available. So one of the problems with moving from an S3 to an S4 is that the packs, that the medications may be different and may be stronger. And I guess that's why we want people to have the conversation. Some pharmacists have sold out. Those that haven't sold out will be able to still sell the S3s as an S4. They will just have to have a prescription label over the top that says this is a prescription medicine only. So some will still have them. But part of the reason for the shortage is the manufacturers have taken the decision that they're not going to supply that particular formulation anymore, and so have withdrawn quite early because they were given enough lead time to do that, because nobody wanted to be left with stock that they couldn't get rid of. Some of them will be. Yeah. I mean, you'd have to probably at this point shop around, but certainly after the 1st of February, the low dose ones with only 10 will be available on prescription. The current configuration. How long that will be will depend on the manufacturers, I would think. Oh no, this is a good question.
That's a good question.
How does CHF and PainAustralia explain to consumers how the brain manages pain without them developing the belief that the pain is all in their head?
Good question, but I'm not sure I have the answer to it. So that's from Rosemary Ainley. Look, I guess pain is complex. We know that there's a physical element that's usually that usually involves some kind of psychological and environmental component as well. And it's never simple. The causes, the underlying reasons why people experience pain are not always obvious and are not always clear. And sometimes there isn't a particular cause. For instance, people like to think that pain and is related to, for instance, arthritis, or there has to be something that causes the pain, and that's not always the case. It's a condition in its own right. So it is difficult. It is not something that is in people's heads. We know that, with millions of people who experience chronic pain, there is a very serious and complex issue here, and certainly any pain specialist will tell you that these things are not straightforward. I guess, in all of this conversation about how you manage chronic pain, what we don't want to see is stigmatisation of people with chronic pain. It's a very legitimate, very debilitating condition, and we want to see better management. We want to see, some understanding of the fact that it is an issue that affects many, many people, and I think this is an opportunity to talk about that and destigmatise it, because it does affect people, and many people are scared to talk about it or to raise the issues because they feel that they might be being discriminated against, or that people are sceptical about their pain and its origin. So I think that's a big issue that we need to, as a community, challenge and look to the solutions and how we can better support and manage chronic pain. And I think the big issue is making chronic pain an issue that is worthy of support, funding, and enabling people to get access to what they need.
Okay. We've run out of time now, so that'll have to be the end of the questions. We had all put together what the next steps were, so I'll briefly go over those. We seem to. So the next steps for us for CHF is that we're producing a consumer resource kit. It's a set of resources for consumer and community organisations to use to talk to people about the changes. The emphasis on where to find help with pain management. I think we're looking at this as an opportunity, so it's not about the ins and outs of the rescheduling decision, except that there will be, it is important that people understand that actually codeine wasn't that effective and there are better alternatives. I think we also need to distinguish that where there is severe pain, pains relating to things like cancer and things, obviously strong opioids are used, and this discussion is not about that particular group of people, and I think that's important, and I think it goes back to Carol's point about the not stigmatizing and not that we need to always look at why people are having pain, and for some pain medication is what works, and we would not want to deny people access to the appropriate pain relief. We're also, so the consumer resource kit, if people want that, they'll be able to get it from CHF, hopefully from Monday. It'll be up, the link to it will be on our website. It's publicly available. It's a slide deck for people to talk with some standalone resources that will help people understand where to go. And then we'll have the continued advocacy for more action on pain, which Carol's already flagged. There's the change.org petition. There's action that we'll be doing media, I'm sure, around the budget. We'll be talking to the government, talking to anybody who wants to listen about how we need more, talking to COAG, talking to the states and territories about how we need to put more resources into pain, into managing pain, and pain needs to be a condition. So I think those are the key next steps. Just there on the slide, and the slides will be up on our website along with the recording of the webinar. Those are just some of the places where you can go to get more information. TGA Codeine Hub, the Real Relief, MPS.org, over-the-counter codeine changes, and Scriptwise as well as CHF. So those are some of the places where you can get more information. Although the change comes on the 1st of February, certainly our efforts don't stop on the 1st of February. If anything, they start to roll on, and we'll be certainly periodically checking in with consumers to say, what are you finding? And I'm sure PainAustralia will be doing the same thing. What are you finding? What difficulties are you experiencing? Are you getting access to alternatives? What are some of the barriers to that? So I think this is the start of a conversation about pain and where we go until we actually get some of these issues addressed. Yeah. So I think with that, did you want to add anything else, Carol, before we finish?
No, I think you've covered it well, Jo, and appreciate everyone's time, and we look forward to continuing the conversation about how we better manage chronic pain in Australia. That's what this issue really highlights, and hopefully the transition on the 1st of February will be a smooth one. And but it certainly does highlight how important this issue is.
Okay. Well, thank you, Carol, and thank you for your time, and thank you everybody for taking the time to participate in this, and to people who asked questions and made comments. And we're always happy, to get any further comments from you. So with that, thank you and have a good afternoon. Thanks a lot.